Functional neurology. Whether perceived as a subspecialty of chiropractic or a name-technique approach, functional neurology has become a relatively popular approach for some chiropractors. It's important to know, then, the basic concepts and approaches of this analysis and management system. A new review does a very good job at doing just that, determining and outlining these main features and presenting them in an organized overview. One comparison to how functional neurology is perceived is the observation that, similar to applied kinesiology, this approach is centered around one individual, the originator and guru. It keeps the importance of the spine and spinal manipulation as an integral part of management, but approaches diagnosis from a novel, somewhat esoteric approach. Management, although appearing to be new, is similar to AK in that it can be traced back to other approaches, some somewhat obscure but pre-existing. Similar to other techniques in chiropractic, functional neurology bases its concepts on known neurologic pathways, but proposes both novel interpretations of neurological relationships and, of course, its own concepts and vocabulary, setting it apart from standard neurology. This inserts a level of perceived sophistication and complexity that, when challenged, seems to be defended by even more of its own unique vernacular and theory. So let's move to a review of this technique and management system to unveil some of the common themes and try to integrate this into the common knowledge of neurology and chiropractic. The title is Unraveling Functional Neurology, a scoping review of theories and clinical applications in a context of chiropractic manual therapy, published in Chiropractic and Manual Therapies in 2017. The researchers made every attempt to enlist a broad range of sources of information, including a textbook on functional neurology. Entitled Functional Neurology by Randy Beck, it's a major source of reference, and although appearing similar to a standard neurological text, the latter portion of the text addresses the concepts and applications of functional neurology with some case examples. The researchers identified 11 articles from the scientific literature. They also reviewed the websites of 5 chiropractors proficient in functional neurology and conducted a semi-structured interview of 4 chiropractors who practice functional neurology daily. The earliest reference to FN is an article published in 1997 by the founder, Ted Carrick, who stated that spinal manipulation can alter the size of the physiological blind spot of the eye, and that this was proof that spinal manipulation has an effect on brain function. It appears that this is the only study published by Carrick as the primary investigator, according to this article review. So what is functional neurology? As described by the researchers, FN is, quote, the detection, evaluation, and conservative treatment of functional aberrations of the neural axis, especially of the brain, unquote. Instead of utilizing the concept of diagnosing and treating a disease per se, FN practitioners approach a given clinical scenario by determining and treating the underlying dysfunction that they believe leads to a particular presentation or named disorder. In FN, neurological aberrations are named physiological lesions or functional lesions. These are described as reversible due to the neuroplastic properties of the nervous system. This is contrasted to ablative lesions, which are defined as only potentially and very slowly reversible due to the fact there is death of neuronal tissue, for example, post-stroke. There are 3 general concepts: dysfunction at the cellular level and those effects on related neurological pathways, and a unique concept, hemisphericity, which we will discuss shortly. At the cellular level, functional neurologists believe that symptoms result from a dysfunctional central integrative state, or CIS, of one or several functional units of neurons within the nervous system. For example, a group of neurons of the right versus the left dentate nucleus. A physiological lesion corresponds to a group of neurons with a dysfunctional CIS. FN considers the central integrative state of a functional group of neurons as the state of health of those neurons determined by 3 parameters that allow the survival and function of neurons. This includes oxygen supply, nutritional supply, and stimulation. So what is hemisphericity? A physiological lesion is said to affect only one side of a brain structure. one side of the cerebellum or one cortical hemisphere, for example, leading to asymmetries of output. The researchers found that mainly in case studies and as stated in interviews or websites of functional neurologists, the following were listed as responsive to their approach. We see here a wide range of disorders, including neuromusculoskeletal disorders, but also more central nervous system disorders, including behavioral disorders. Unique to FN is how dysfunction is detected. A major sign of a dysfunctional CIS is fatigability of tested neurons. In other words, the response to a continued or repeated stimulus cannot be sustained as it should. A target effector has to be tested bilaterally and also simultaneously bilaterally in order to find the faulty side because of the concept of asymmetrical function or hemisphericity. This is also based partially on the concept of neurological extinction, which means that when tested unilaterally, a deficit is not found, but when tested simultaneously with the other side, it's revealed. Also, FN purports that a physiological lesion does not always produce symptoms, so there should be an attempt to detect minor asymmetries, which are believed to be clinically relevant. Here's an example. In particular, when weakness, coordination, or balance are issues, the cortico-reticulospinal tract and connected pontomedullary reticular formation are assessed. The cortico-reticulospinal tract originates at a cortical hemisphere, passes mainly through the ipsilateral pontomedullary reticular formation, and terminates for the most part in the ipsilateral spinal cord. To understand the clinical manifestations of dysfunction, here's a summary of normal functions of the cortico-reticulospinal pathway. It includes ipsilateral facilitation of muscle tone, ipsilateral inhibition of anterior muscles above the spinal level of T6 and of posterior muscles below T6, ipsilateral inhibition of pain sensation, and ipsilateral inhibition of sympathetic nervous system stimulation. So you might note that the crossed innervation that is standard for the understanding of the corticospinal tracts is not what is being focused on as one might do when determining the effects of a stroke, for example. So the clinical result of dysfunction of this pathway is a global ipsilateral decrease of muscle tone. Posturally, this would be seen as a flexor angulation of the ipsilateral upper limb and an extensor angulation of the ipsilateral lower limb, a posture known in FN, oddly enough, as pyramidal paresis. This is due to the lack of inhibition of the upper flexors and the lack of inhibition of the lower extensors. Also possible are one or more ipsilateral pain syndromes and an ipsilateral increase of sympathetic activity leading to a number of autonomic signs, including an increase of blood pressure, increased sweating, or a large pupil size. Another unique example for FN is the blind spot. The blind spot is described as the area of the retina devoid of photoreceptors. In other words, the area where converging retinal ganglion cells exit the eyeball to form the optic nerve. The perimeter of the blind spot can be mapped out during the examination of the visual field to detect some eye pathologies and to follow their progress. However, Carrick claims that in the absence of eye pathology, the size of the blind spot can be altered in response to the central integrative state of the visual cortex and by extension the CIS of one hemisphere, which would depend on the afferent inputs received from the thalamus through the thalamocortical radiations. Treatment is often multifaceted with certain guidelines. The intensity of the stimulus has to be progressive and adapted to the degree of fatigability of the targeted groups of neurons. The type of the stimulus and the side of their application depend on the characteristics of the stimulated pathways. The stimuli has to be repeated, and a single physiological lesion can be affected by several kinds of stimuli. The effective treatment has to be reassessed regularly by testing the positive indicators found during the initial clinical exam. As discussed earlier, the main state of neuronal health, according to functional neurology, involves three parameters. These are addressed in many of the treatment plans regardless of the specifics of that dysfunction location. For example, for oxygen supply, breathing exercises are prescribed, and for nutritional supply, often B vitamins, omega-3s, and coenzyme Q10 are given, and for stimulation, repetitive movements are directed at the specific focus of dysfunction. So here are some reported approaches to specific conditions. One obvious common area for the ones listed on this slide is dysfunction of the right cerebral hemisphere or hemisphericity. So for migraine and vertigo, we have dysfunction of the right cerebral hemisphere, with management including spinal manipulative therapy, eye exercises, breathing exercises, and nutritional therapy. For attention deficit and hyperactivity disorders, also dysfunction of the right cerebral hemisphere, but also the left cerebellum. Management also includes spinal manipulative therapy, sound therapy, spatial rearrangement exercises, breathing exercises, and nutritional therapy. And for low back pain with nerve root compression, also dysfunction of the right cerebral hemisphere, management including SMT, breathing exercises, and nutritional therapy. Although we might describe functional neurology as relatively new, what about the treatment approaches? Are they new? It's interesting that Ted Carrick, in an interview, actually stated that the treatment approaches are not new, just novel in the connection between the diagnostic approach and management. By simply typing into a Google search some of the treatment approaches commonly used, we can see their pre-existence and often context of prior use. Let's start with exercises given to patients with balance issues or vertigo called Cawthorne-Cooksey exercises. Here we see quite a few descriptions of these and how they are, for some practitioners, standard approaches to patients with vertigo, perhaps not quite so obscure, but not commonly taught. Let's try another. For those with concentration or memory issues, FN practitioners often prescribe listening to Mozart. Here again we see this is not new. In fact, this was generated by Eastern European and Russian research in the late 1970s, resulting in a popular approach to strengthening memory. It's based partly on the rhythm and cadence commonly found in his compositions. Ironically, under the search finding entitled "Which Learning Disability Did Mozart Have?", the authors speculate that Mozart may have suffered from ADHD or Tourette's, two conditions for which Mozart music listening is prescribed for using FN approaches. And yet another common approach, mirror training. Again, with a simple Google search, we see a number of listings. One is a textbook on stroke medicine. Here's a page from that text. It becomes clear that for stroke rehabilitation, this approach is used by many. The basic approach is to use a mirror placed so that the affected limb is hidden from view. Movement of the normal limb is visualized by the patient, making it appear that the affected limb is functional. The researchers found no randomized controlled trials that could confirm the therapeutic effect of the FN approach as a supplement to traditional chiropractic on any clinical outcome. And no study design other than case reports currently exist that describe therapeutic outcomes in symptomatic patients. So the obvious question, given the popularity of FN, the number of practitioners, the FN state-of-the-art treatment facility, and the cost of seminars, why is there no research being published? So although there may be some value in the management approaches used, critically thinking clinicians and researchers eye this lack of scientific evidence with suspicion.